Hi everybody, we'll be starting shortly. We're just letting a few more people in. We will be recording. If you have any issues, please place this in the chat. We'll be starting in about a minute's time. Thank you. Good afternoon, everyone. It's great to see so many of you, as well as firm friends of our seminar series and new people, including students. So welcome to you all for our MAHSC seminar for April. We have some housekeeping slides as well as our presenters for today. Jane, I seem to have lost our housekeeping slide. Thank you. So as you know, the seminars are in conjunction with the University of Manchester, Health Innovation Manchester, and the Manchester Academic Health Science Centre. We're very pleased to welcome you to April's seminar, which is titled Occupational Health Research and Regulatory Sciences During a Global Pandemic. And this is very much designed to be not just an introduction, but an in-depth look at the Thomas Ashton Institute, one of our cross-faculty institutes within the university. And I'm so pleased to have two of the key people that are going to be speaking to you today. So I'm going to introduce Professor Neil Bourne, who's director not only of the Thomas Ashton Institute, but also of the University of Manchester at Harwell, and Professor Martie van Tongren, who's our chair in occupational and environmental health, and also in charge of the health theme within the Thomas Ashton Institute. So we will ask you to put yourself on mute and switch your video camera off. When it's questions and answers, we hope that you've come up with some key questions for our speakers. You can either use the chat function, and I'll be monitoring that throughout the talks, or when it's time for the Q&A, you can switch off your camera, raise your hand under reactions, and we'll be pleased to take your questions then. As I said before, we will be recording this session and it will be available on YouTube shortly. So without further ado, I'm going to ask Professor Bourne to take the stage, and also then hand over to Professor van Tongren. And hope you enjoyed this seminar, and we're also looking forward to welcoming you for the May session, which is listed here in AI. So without further ado, can I see if Neil can share his screen?
Okay. How does that look?
Thanks. They'll just need it.
Can everybody see that?
Brilliant. Thank you, Neil.
Excellent. And thank you so much, Arpana, for introducing me. So welcome to you all this afternoon. I'm Neil Bourne, and as Arpana was kind enough to say, I direct the Thomas Ashton Institute, and I'll give an introduction to that very shortly. I also direct the University of Manchester's presence at the National Laboratories at Harwell. And if you don't know of that, it's worth me bringing it to your attention, because we do have a lot of capability there to help research using the synchrotron, the neutron source, the lasers, or the supercomputing down there, particularly across the biology and medical field, because of the great work that's going on and the national effort that's based at Harwell around, for instance, the vaccines for COVID, and a lot of the work on the molecular biology, which has gone into looking at the virus and so forth. So please do get in touch if you have any interest in those areas, and very keen to help you and put you in touch with the relevant parts of the facilities there. But as for today's lecture, I also direct the Thomas Ashton Institute. This is a collaborative partnership. It was launched in 2018, and it is a jointly run, jointly managed institute between the University of Manchester and the Health and Safety Executive. And that makes it absolutely unique within the UK and indeed internationally. Our history was based around Thomas Ashton, who was someone who supported the university in its early days. As you'll see, he was absolutely instrumental in helping workers at the time of the cotton famine. And so he was particularly known for his social responsibility. And obviously the university itself celebrated becoming #1 in the world for social responsibility in the Times rankings across the world's universities last week. So what we're trying to do is to combine the great breadth of the Health and Safety Executive's interests, which is across the whole of the world of work, with the depth that the university has in being able to apply particular research to give the evidence base on which regulations can go forward. And that's really the key modus operandi that we have here, to support the regulations and provide the evidence to make them better. And so in that respect, we cover a whole series of different areas where we can try and see the different components of the world of work. Obviously, at the core of that is the people and their health that are within the workplace, that are doing their individual jobs. We're interested in the occupational health aspects, and I shan't talk about those much further here, because obviously Martie's going to follow me in a moment, and he's going to be able to tell you a lot more about that. But we're not only interested in the effects of work on health, but the effects of health itself on work and the way that work is organized, managed and constructed.
7 تا 8 بعد از ظهر افطار تبرکی یادمون باشه.
Sorry? I heard someone talking there. I don't know what happened on the input. Okay, so we're also interested in the plant in which people are working, particularly in the structures that they're adopting. And within that, we're looking at all the individual components of those structures. Some of those are around the advanced materials that are used. And obviously the HSE has a role in licensing and approving those materials for use in new components and products going forward. Particularly, we're interested in ensuring we understand how components fail. And it's the failure of those components and the ability to test them that HSE have to do when they're looking at accident investigations. For instance, obviously there was a disaster some years ago at Buncefield, where a large container full of petrochemicals exploded, and that was down to a failure in the actual structure in which the petrochemicals were being stored, but also the controls that were being occupied. And in the end, one of the features of all of the accident investigation side turns out to be the human factors and the way that the humans operate the different procedures that they're putting into place here. And then sitting on top of the people and the plant are the processes by which work is organized. And particularly in the modern world, we're moving to a digital age where a lot of those processes are monitored, managed, and then analyzed afterwards by digital methods. Increasingly, we're using sensors in the workplace. Remote monitoring happens with cameras on sites observing the world of work and then the individual processes that happen within there. And then obviously that gives us some insight into how disease might be transmitted around an individual workplace whilst we're in particularly the pandemic conditions of today. So we have various programs running across the Institute looking at these new processes and the digitalization factors around that. Particularly a large program with HSE funded by the Lloyds Foundation called Discovering Safety. And that is looking at different digital methods, including analysis of workplace records on various incidents in order to learn how to produce a better, safer workplace going forward. And then on top of all of that, we have the complexity of the systems that sit at the management level, at the leadership level, but also at the government level to try and enforce and help the processes give you a safer workplace at the end of all of this. And at that point, we're interested in how risks are distributed around the workplace itself, whether that's within the working task, whether it's in the individual control processes that are being used, or whether it comes external to the organization from other areas that can be controlled. And across all of these, it may be that the various risks that we're considering are ones that are at an individual level or ones that are at a global scale. And it's that effect of scale of a risk with an individual at one extreme, all the way through to the risk on maybe even a nation at another, looking particularly at the present environment, for instance. And that how you map from the individual to the macro scale is of great interest in all that we're trying to do. So hopefully that gives you an overview of where we are. And the ultimate goal of all of this is to try and produce a more resilient workplace at the end of it. So we bring together expertise across psychology, across engineering, and across epidemiology in order to understand all of the individual components of this, which gives us a span across all three faculties of the university. And I think we've been very successful. One of the few very large institutes that cross all three faculties in managing to get the different capabilities integrated in a way that we can produce a common view on the way forward with a particular problems. And one of the things we do, working with the health and safety executive as partners, is actually to engage in programs together. And I'm going to come to some of those in a moment. So just to summarize over the Institute itself then. We have assembled an institute which is a partnership. It's got the world-class capabilities of the Manchester academics, along with the international excellence of the Health and Safety Executive. We're addressing the real-world issues that come from government and come from the workplace. And we're doing so with the academic rigor to provide the evidence on which decisions can be made. And we hope that we got unrivaled depth and breadth in doing so that allows us to bring the regulatory experience that exists in the 40 years that HSE has existed to produce a really unique, trusted brand in what we do. So we have 6 individual areas where we have expertise, and each of these themes has a lead, both from the university and from the Health and Safety Executive, that work in tandem to deliver their individual theme. Digitalization and complexity is one. Leadership and well-being is another. Social change and inequality is another again. Safer infrastructures, reliability and resilience, and finally workplace health, which is led by Martie van Tongren, and we'll hear from Martie in a moment. Those come together to allow us to attack various problems. And hopefully at the end of this, allow us to bring together capabilities to ultimately hone the regulatory craft, to make better regulation, to end up with a healthier and safer operation in the workplace at the end of all of this. And that might be various methods, including the one on the right-hand side of this diagram, where there's a little nudge indicator here to end up with a healthier male toilet while you're engaged in your activities in there. So we have particular pillars in the Faculty of Medicine and Health in workplace health, as I mentioned. We have another pillar in the Faculty of Science and Engineering around the safer infrastructures. And across those, we have the platforms that cover the psychology, the leadership, the risk assessment, the inequalities, and the digitalization that allows us to bring together all our capabilities. And in doing that, we deliver some large programs. One of those that I'm going to mention here, and I'm sure Martie will mention another shortly as well, is keeping the UK working safely. This is a project where we're trying to build a biosecure construction sector for the future world of work. We've completed scoping studies on that, and we've looked across 5 key areas there, both transmission across the workplace in construction, the use of technologies to shield the workers against future transmission and illness because of the way that COVID spreads, the use of data and simulation tools to predict from sensor data what's going on, the leadership roles that go forward, and then finally the way that we look to deliver construction projects from a top level in a better way to ensure biosecure working. And one of the key things that has come out of the first part of this, which involved us interviewing a range of workers and managers across the companies involved in this, and you can see there were 4 big multinational construction companies there, was that for me, it was the employee and contract staff voice that was the key message. They were worried about their physical health and their mental health in a COVID environment, but principally, they were worried about the economic impact that the pandemic was having on themselves and their families. And we'll be picking up on this and what we do going forward. So you can see on your screen here a list of the sort of research areas that we're adopting and we're working on and we're going to work on going forward. I won't go through these now, but I think this is a suitable time for me to perhaps pass over to my colleague Martie and hope that he can tell you more about some of these individual projects that I've referred to in what I've said up to now. So from my side, thank you very much on behalf of myself as the Manchester director of the Ashton Institute. I pass on my welcome to you as well from my colleague, Professor Andrew Curran, who's the HSC director of the Ashton Institute. And hopefully Martie can tell you some more about some of our activities.
Thank you, Neil. I'll share my screen if that's okay. Can you see that? Is that Neil?
Yeah.
Can you, yeah. Okay.
Thanks, Martie.
Thanks, Neil. So yeah, I'll talk a little bit about the kind of occupational health research that we are doing at the University of Manchester, and I wonder whether this date was specifically picked for this presentation, as it's today. It's the kind of World Health and Safety at Work Day, so it's quite appropriate that that this presentation is given today. So I'll talk a little bit about the kind of work that we do, and I'm particularly emphasizing the work that we do in terms of collecting data about occupational disease, and also some of the more recent work that we're doing in relation to COVID-19. So the Center for Occupational Environmental Health, which I kind of lead within Arpana's division, is the oldest still an existing occupational medicine and health department in the UK, and it is was set up by Professor Ronald Lane in 1945. And I don't know whether my mouse works, but that's Professor Ronald Lane, who set up this department, and we still have an annual Lane lecture in honor of him, and he basically was very successful in setting this up and doing research, very useful and important research in a whole range of things, including kind of cotton and the effects of cotton dust on workers. On the right, you see some of my more recent predecessors, Raymond Aegis, who was professor between 2002 and 2017, and then before that Nicola Cherry. Hopefully next time, we'll have a color picture of some of these the recent professors. And so, why is occupational health important? So these are some of the stats that I picked from the Health and Safety Executive website. So in 2019 and 2020, in that year, we had over 100 fatal injuries. I had to look this up to see whether this was correct, but there's 1.6 million working people were suffering from some form of work-related illness in Great Britain. And in total, there's about nearly 40 million working days lost due to work-related ill health. And that's not just a problem for people suffering from ill health and personal issues, but obviously that also has a great cost to the economy in Great Britain, up to a total of about £16 billion a year. So I think even before COVID and the pandemic, I think it's clear that occupational health and safety is an important issue to still work on trying to reduce these impacts. So within the team that I'm leading, and I've inherited a kind of a program of work that's called the Thor Research Network, the Health and Occupation Research Network, and that's a network where we work with several hundred physicians across Great Britain who voluntarily report to us when they see a patient with symptoms or disease that they believe is caused or aggravated by their work. And at the moment, we're working with occupational physicians, we're working with chest physicians, skin dermatologists, and general practitioners. And in the past, we had some other kind of schemes that unfortunately no longer existing. And some of the stuff that we can do with that data is looking at trends over time in terms of occupational ill health. And this slide shows a kind of relative trends of incidence in total work-related ill health, total musculoskeletal disorders, and total mental ill health. And you can see clearly from this graph that total mental ill health became a lot more popular, and I say that between brackets, since the mid-1990s. That's mainly caused by an increased recognition of that issue and probably a reduction of the stigmas surrounding kind of mental ill health. But that led to a rapid increase in work-related mental ill health issues in Great Britain. And then after that, it stabilized somewhat, perhaps it going down a little bit, but other statistics shows that it's relatively stable. And similar trends have been seen in other kind of work-related ill health. So this slide shows again a relative trend of over time of occupational asthma, which can be caused by chemical agents or animal laboratory kind of enzymes or proteins or flour dust from bakery activities. And since the turn of the millennium, I think we've made reasonably good progress in reducing the kind of incidence in occupational asthma by about fourfold from 1999 till about 2014. Unfortunately, since then, it looks like there's been an upturn, and that the incidence in occupational asthma has been on the increase again, and the levels kind of appear to have doubled between that, and that's kind of confirmed also by other data that comes from the labor force survey. And in this day and age, I think in terms of COVID, when we're very interested in making sure that surfaces are cleaned, it's also important to realize that cleaning agents and disinfection agents can result in respiratory symptoms to people who are either using the cleaning agents or are exposed otherwise. So this is a slide that shows some of the occupations that are at higher risk of respiratory disease due to the use of cleaning agents, and that include housekeepers, cleaners, but also nurses and nursing auxiliary and assistants, because as you are well aware, disinfection products and cleaning agents are heavily used within hospitals to reduce the risks of infectious diseases. And particularly now, I guess there will be the amount of these products that are being used is probably vastly increased compared to a number of years ago. So in addition to kind of looking at transmission risk, it's also important to make sure that these kind of products are used safe and do not cause excessive kind of impact on people's health. So occupational health during the pandemic, it was I have to kind of say it was quite an interesting period, or it is still an interesting period in terms of occupational health. It tended to be, until last year, quite a niche area of work. Didn't really receive a lot of attention in the public domain, but I think since last year, terms that are very familiar with in the occupational health world have become quite common in even in mainstream media. Things like workplace risk assessment, risk management, the term hierarchy of control, to make sure that we're trying to reduce risk as much as possible through a kind of a system where we're trying to eliminate, substitute, and eventually come to PPE is now much more widely kind of recognized as a kind of a tool to try to kind of see what the effectiveness is of control measures, rather than just jump straight away to personal protective equipment. And discussions around airborne exposures, about surface contamination, are now kind of very kind of prominent in various part of society. So in a sense, and these are kind of terms that, like I said before, we are kind of dealing with in occupational health quite a lot, and also clearly there has been a lot of discussions about the risk of transmissions in the workplace, and one of the results of this is that I was approached by Andrew Curran, who's basically the co-director of Thomas Ashton Institute with Neil. Andrew Curran kind of approached me kind of during the sometime during the year last year, and kind of with the idea that basically he'd been asked by Chris Whitty and Patrick Vallance to set up a national core study to address the kind of key knowledge gaps in relation to transmission of the virus in environments, in occupation, and indoor environments. And clearly, I kind of said yes, and since then, I've been working quite a lot on this project. And CUPS, that was mentioned earlier by Neil, is part also as of this Protect kind of collaboration. And the really key objectives of this is to kind of understand the kind of transmission risk, learn from workplace outbreaks, to really kind of derive evidence that can support a kind of a safe return to to opening up society again, and identify what kind of interventions work, and developing tools to understand better and being able to study the respiratory virus transmission risks. So that project is split up into 6 themes, which you can see here from this slide. It ranges from outbreak investigations to risk modeling. I lead the sector-specific studies, which I'll say a little bit more about. Alan Bennett from PHE kind of leads a theme that is about monitoring of viruses in environments and surfaces. Professor Wendy Barclay from Imperial College London is included in this project as well, and basically we're trying to use the studies that he's setting up in terms of experimental work in relation to hamsters and also humans, to understand a kind of a shedding of the virus and transmission events. And then finally, theme 6, led by Andrew Curran, is trying to pull that all together into some meaningful kind of guidance and evidence and tools. And the University of Manchester is involved in 4 of those themes, mainly from the School of Health Sciences. We're involved in theme 1 and theme 3. Theme 2 is led by Ian Hall from mathematics, and theme 6, the CUPS projects that Neil was talking about, that is done through the Thomas Ashton Institute, feeds into theme 6, that's led by Andrew Curran. So the theme that I'm leading briefly is including 5 kind of work packages that where we do a mixture of qualitative research, quantitative research, evaluating of existing databases, analyzing existing data, and also, synthesizing that evidence into sector-specific evidence reports. And we'll mainly say a little bit about what is known currently with looking at some of the data that has been previously collected by ONS and other organizations. So this slide shows the mortality rate for COVID-19 in England and Wales by major occupational groups, and you can see that the risk is increasing in when you go more towards the occupations where we probably traditionally call them kind of blue collar or manual work. So elementary workers are at the highest risk of dying compared to the managers and professional occupations, and clearly the caring, leisure, and other service occupations have also kind of an increased risk. The ONS presented kind of mortality analysis that were adjusted for age and gender, and they showed that there were quite a number of specific occupations that had an increased risk of dying of COVID-19, and that included, for example, occupations that were taxi drivers and bus drivers and others. However, they interestingly, kind of healthcare workers weren't identified as having an increased risk of mortality compared to others, and that's probably because many of the deaths that have occurred in among healthcare workers may have been referred to the coroner, and if they are referred to the coroner, then there is a delay in that data being included in the ONS mortality statistics, and hence it may well be that over a period of time these cases are being introduced, and we'll see slight differences in these results. The other thing that is of interest is that like I said before, the ONS mortality analysis were adjusted for age and gender, but not ethnicity, geography, and deprivation. And we've done some analysis that unfortunately I'm not allowed to show you yet because of apparently the imminent elections. But we've done some analysis with linking census data with the mortality statistics that allowed us to correct for ethnicity and for geography, and it shows that the differences in risk between occupations were greatly reduced after correcting for these factors, although they're still existing. And that's really kind of an important point, because it shows that although there are differences in these occupations, they're not necessarily just purely workplace risks. They are we kind of understanding now that transmission is a continuous risk that is not really demarcated in either workplace or other kind of activities. But some of these kind of activities, some of these factors are concentrated in some occupations, and hence that's why they are kind of leading to an increased risk of mortality and disease. This is another kind of slide that shows some of the statistics in relation to infection this time, and it shows that some of the occupations that are the lower, and then some of the occupations that are at a higher risk. So the top one shows the higher risks compared to the lower. The skilled agriculture and related trades, for example, are at a relatively low risk. And these were produced by ONS, and they also done some analysis that then corrected for ability to work from home and social distancing at work. And then some of these kind of differences disappeared, which is perhaps not surprising, because obviously these are kind of risk factors that you're interested in. And finally, and apologies if this slide is a little bit difficult to read, but this is data from a group in Glasgow that used the biobank, the UK biobank, to analyze the effects of the differences between occupations in relation to severe COVID-19 cases. And here, actually, we do see quite a strong effect on healthcare workers, which are on average about 7 to 10 times at a higher risk compared to non-essential workers on the left. And that it's quite interesting that we find different results in different data sets. So some of that is summarized here. So we find important differences in mortality between occupations, but some of that is reduced when we take into account some kind of other factors. That ONS mortality data, we didn't see any observed excess risk in healthcare workers, but that may be due to the fact that these cases, many of these cases, may not yet be included into the mortality statistics. In contrast, biobank analysis shows that there is a large excess risk of severe COVID-19 among healthcare workers, perhaps less so in social care workers. One of the problems here is that the case definition includes the necessity to have a test in hospital, and it may well be the case that healthcare workers are more likely to be tested in hospital and therefore more likely to be included in the cases in this analysis. So what does that mean is that we're getting slightly mixed messages and different messages from different studies. And within the Protect study, we're trying to make sense of these kind of differences. We're trying to kind of do further analysis and do other analysis of the mortality data, the infection survey data, but also some of the other data that's been available. And then trying to, through some triangulation processes, kind of synthesize evidence, meaningful evidence in relation to work-related risks. So that's really what I wanted to say a little bit about briefly what we're doing in terms of Protect. I wanted to just finish with some of the early kind of outcomes of the study. Protect started in November last year. We had to kind of start quite quickly with this work, and in fact we didn't really have any contracts until January, and we had to deliver our first results by March. So it was quite a project that was difficult to set up, but we've through the various themes and also kind of leaning on kind of data from other studies, we came to these general statements, and the first one I kind of already mentioned: transmission is a continuous risk. We can't it's not just happening at the workplace, not just happening in the home, but it happens in various places, and that makes it perhaps quite difficult to just kind of study it as a workplace risk. Based upon some of the stuff that HSE has done, they basically have found kind of evidence that control measures in most workplaces have been implemented well. But as I mentioned before, workplace can act as a vehicle to concentrate other risk factors and increase opportunities for transmission. I would add to that, okay, maybe control measures have been implemented well in most workplaces, but there are obviously other workplaces where control measures have not been introduced that appropriately. So key risk factors include geography, demography, and geography is an interesting one because there's now also an increased interest into understanding the reasons why certain geographical areas in Great Britain seem to be different in terms of having maintaining a kind of an increased prevalence and transmission compared to others. And that will be a combination of all these factors that are listed here, such as socioeconomic status, deprivation, ethnicity, the type of jobs, the type of sectors, transport links, etc., and individual behavior and culture. I'm sure that we're all aware that this whole discussion about these transmission, different transmission routes, and I nearly included a slide about that specifically, but so the three transmission routes are the droplets, the airborne transmission, and the surface transmission, and it's clear that well, it's clear, I think, at least in a large part of the scientific community, that the aerosol is an important one and probably has been underestimated in importance from the early start of the pandemic. But also kind of like, and very importantly, behavior modification and effective communication and effective control are key in reducing the risk of transmission. So with that, I kind of want to, I'll end here, and I'm happy to answer any kind of questions. These are a list of people that have contributed to some of the work within the University of Manchester and some of the other organizations, and I probably have missed people out on this list, and I apologize for that. But with that, I'm happy to answer any questions.
Thank you so much, Martie and Neil, and especially for sticking to time. It was pretty much spot on. People are feeling a little bit shy for asking questions, so that gives me opportunities to ask mine. Oh, actually, sorry, I spoke too soon. We have some coming up now. So I'm going to start off with Chris's question. When looking at environmental data, has anyone looked at the possible links with the SOAR report?
So the so the SOAR report is in relation to ethnicity. Is that correct? So I mean, it's obviously when looking at when looking at any kind of risk factors in relation to COVID-19, they can't be, you can't look at work-related risk factor or other risk factors without taking into account a whole range of other kind of issues and ethnicity, other demographic kind of statistics or information, geography. All of these appear to be important, and I think personally, I think part of the differences in ethnicity can possibly explained by occupations, and perhaps also the other way around. Part of the differences between occupations can be explained by ethnicity, and I don't think there is a clear there's a clear distinction between those two. And well, not a clear distinction. Well, what I mean is it's very difficult to pull these different factors apart completely. So yeah, it's important, and it's always important to keep these other factors into account. When we looked at the mortality data, actually geography was actually the most important, I think, factor in reducing those differences between occupations, but also ethnicity kind of explains some of that too. I hope that answers the question to some extent.
Thanks, Martie. Marine wanted to know about the aerosol and droplets. So why wearing surgical masks can help us in the fight for COVID.
Well, no, surgical mask for me is and there was, I think, at least in the beginning, quite a lot of confusion about masks and why people need to wear masks, and that differs between different kind of settings. So within a healthcare setting, when working with patients who are or COVID-19 patients, it's clearly important for the healthcare worker to be protected, and hence that they use personal protective equipment that prevents the inhalation of airborne material, and that will require masks that are properly fitted and properly designed to prevent that. And that you'll see terms like N95, FPP2, FPP3 kind of type mask that are specifically for that, and that's protecting the individual from inhalation. Now, some of the other kind of masks and face coverings that we are advised to use in other settings and in indoor settings is really kind of like an emission control measure, which really kind of like, if you put something for your mouth, you are much less likely to emit to greater distances kind of aerosols and droplets. And that's why masks are important to wear in indoor environments.
Thanks, Martie. Very important to just highlight those very important differences between face coverings and protective equipment. To give you a break, I'm going to just slip in my question to Neil, because I think one of the most important innovations is the Thomas Ashton Institute, and that ability to work across the disciplines in this really important area. And I think both of you demonstrated the fundamentals of epidemiology and also qualitative research methods to bring in that evidence base that can then be used by policymakers, by governments. And so, Neil, my question really is, where now for Thomas Ashton? And what can we do as either members of the public or part of the NHS or university to help you with your vision?
Right, wow, that's an excellent question and opens up a whole series of possibilities. The Thomas Ashton Institute is unique in the way it's set up, but I mean, certainly since the pandemic arrived, obviously at the beginning of last year, the perception of risk amongst the general public is absolutely key to how we now consider the way forward. We're almost talking about Thomas Ashton pre-COVID and post-COVID. And now that we're all aware of what risk is, the public communication of risk is one of the key features that we at Ashton want to do going forward, to make sure that people understand its consequences, and how, you know, you're going to look at that from a personal perspective, or indeed from an organizational or a national perspective, from the regulator's point of view. So we're looking at a whole series of areas around that communication agenda. That's certainly one of the ways we'd like to go forward. The idea as well that we can start increasing some of the assessments of impact that come out of the sort of studies that Martie, for instance, has been talking about now, is another area. We have 6 themes at the moment, but the effects of economic impact have clearly been very serious amongst the pandemic, and probably have controlled the geographical factors that Martie was talking about, you know, that's coming out of the data. And so the institute itself, and I was discussing this with my HSC director, Andrew, last night, may look to bring that in as another theme going forward, in order that we can include that within the considerations we make. But, you know, that has important consequences. Things like the levelling up agenda are going to be, you know, a key part of this, because obviously the sort of incidence of COVID is related to some of the political, geographical agendas that government has in policy as well. So it's a fascinating time for us, and I can only thank all of the faculties, particularly yourselves and you, Arpana, again, particularly on top of that, for allowing us to really start this institute in the first place. And we look forward to working together to push this forward.
Fantastic. We look forward to working much more with the Thomas Ashton, and as you said, I think only good things will come from this collaboration, and we'll post in the chat the website for people to get more details. Martie, I think Augusta's question is for you on the Thor project. Are GP surgeries from Manchester involved, and how do data get from the GP surgeries to your team?
So there will be some GPs in Manchester, but we are, I don't know how many, and certainly not all of them. So what we do is we only recruit GPs who have had training in occupational medicine to some level, to CPD level, that can be included in our kind of GP Thor kind of scheme. So they have expressed an interest and have some on basic training in occupational health. So those are recruited, and in it's a voluntary scheme. physicians don't get paid to do this, so it's a voluntary scheme, and they report, on a monthly basis, just on either online or on brief kind of physical cards that they send to us. That probably a pile lying somewhere in the university, kind of waiting for us to come back to enter into our systems. But
thanks, Martie. Question from Martin Regan. Is there work ongoing in respect to occupational specific hierarchies for the control of COVID-19?
Not necessarily in terms of that system of the hierarchies, but we are looking at the effectiveness of different control measures, and some very specific kind of controls that have been proposed by people, and some of them probably not very effective and not very sensible kind of types of control measures. But what we are doing and what we are now being involved in is in a Cochrane review that looks at the kind of evidence of interventions in the workplace to reduce kind of transmissions. So that is just starting now. That will look at the broader picture of different types of control measures.
Thanks, Martie. Neil, in terms of regulatory sciences and the impact that we can have either as researchers or healthcare professionals, I think there's been that real need for input into it for real life research. I just wondered if in this current situation, whilst we're almost diverting a lot of our efforts to COVID, just wondered if there were some key non-COVID issues that the regulatory side of things need addressing.
Yeah, I think that's a really good point, because one of the worries that certainly talking to HSC that they have is that there are a whole load of workplace health issues that aren't being addressed while everything is being concentrated into COVID. And certainly that the underlying issues still exist. Musculoskeletal issues, respiratory issues, all of those are still there. Work is still happening. Workplaces are still causing disease for the workforce, and obviously all the efforts that happen, within your group that are doing that sort of work, within your division that are doing that sort of work, are really still key going forward. And I'm sure that HSC will rebalance when we come out of this pandemic. We just have to hope that that's soon. I do think that there are going to be lessons learned out of all of this. And I think it's going to be really key for us to look at those, because that will change the way in which the regulator operates. And as I say, the regulatory craft, I would say, is at a balancing point now, where they're looking at the ways they'll consider themselves in the future, and the ways that they'll operate. Particularly in a world where we're not within Europe anymore. So there's the new Brexit issues to take into account as well.
Thank you, Neil.
So there's a great opportunity for researchers in Manchester to contribute to this.
Yeah, definitely. And Martie, would you mind addressing some of the questions around the data that's available? The specific question is about mortality and when things get referred to the coroner. So how representative are these data sets that we can currently use when we're looking at occupational settings and COVID, and whether that is truly representative?
Yeah, that's an important question. I think it affects only the mortality data. It doesn't affect some of these other data that we are working on. it's a little bit difficult, if not impossible, to get information out of the coroner in terms of what has been referred to them. So we tried at the beginning to get at least some information from the coroner in England to see what has been referred, what's the numbers. We don't really, they weren't interested or allowed to kind of share that information. So we don't really know, to be honest. We expect that a significant number of cases in the healthcare workers that are being referred to the coroner, and hence I would the statistics for mortality for healthcare workers I would probably treat with a pinch of salt, I guess, at the moment. I think the others are probably more representative, and I think the others are less likely to be referred to a coroner because of there was just a lot less attention of those kind of occupations. So I think the others are probably representative, but the healthcare workers, I think you probably wouldn't necessarily want to quote as definitive. Yeah.
Thank you, Martie. So I'd like to thank our speakers today, Martie and Neil. A huge thanks to Jane, who organises everything so beautifully. And thank you to our audience for some great questions. As you know, we do these monthly, so we hope you'll tune in again for AI, for the May Seminar Series, and we will be putting this onto YouTube as well. Jane has kindly put on the link to the Institute for you to get more information and sign up to the newsletter. And last but not least, thank you to MAHSC, the University and Health Innovation Manchester for the opportunity to have this seminar series. So see you again in May, and thank you ever so much. Thank you.
Thank you, everyone.
Thank you.